Right, now we go on to the treatment, which is the most important part. And as I mentioned previously, most of the questions that you will get in the examination will be from the treatment part. So the following factors are taken into account for selecting an appropriate therapy: tumor stage, phenotype, whether it is B cell, T cell, or natural killer cell, histology, low grade, intermediate grade, or high grade. Then, low grade are well differentiated, high grade are poorly differentiated. We look at the symptoms, presence of B symptoms, performance status, whether the person is active or he is active more than 12 hours, less than 12 hours in a day, whether he is lying in the bed all the time, okay? Patient's age above 60 or below 60, comorbidities, other diseases like hypertension, heart disease, lung disease, diabetes, all these are comorbidities. Then it is administered in different settings. Okay, you can give it in outpatient at an infusion clinic, and when certain protocols are given, not all protocols. So chemotherapy can be given in an outpatient treatment by oncology nurses. Growth factor support like granulocyte colony stimulating factor, or erythropoietin, or granulocyte macrophage colony stimulating factor. These are given to stimulate your bone marrow, because when you give chemotherapy, all the dividing cells are killed, particularly the cells in the bone marrow. They are very rapidly dividing cells, like the white blood cells and the red blood cells and the platelets. Okay, so we get problems over there. But certain types of therapies are there for which you have to admit the patient, inpatient treatment. For example, infusional cyclophosphamide, doxorubicin, etoposide, which have got serious side effects, and you have to give them continuously for 4 days. So you have to admit the patient. If you have to do a bone marrow or stem cell transplant, then obviously you have to admit the patient. Initial treatments of patients with intermediate or high-grade lymphomas, bulky disease, which means the size of the tumor is very big, and patients with complications like pain and dehydration. For these patients, you have to admit the patient, okay, for these cases, Right, and here is the drug list, and I've written that it is very important, right? You should try to memorize all these drugs, and you have seen them all. You've seen them in your pharmacology. Some are new drugs that you might not have seen in previous lectures and also in pharmacology. For example, histone deacetylase inhibitors, vorinostat and belinostat and romidepsin. This is new for you. And PI3K inhibitors you have seen in previous lectures, copanlisib and idelalisib. Okay, so these ones. Then colony stimulating factors, erythropoietin, I just mentioned them. And then you have got monoclonal antibodies, anti-CD20, rituximab. These are important, okay? All of them are anti-CD20 except these two, lemtuzumab and pembrolizumab. You have seen pembrolizumab in previous lectures, okay? Then you have seen CAR T cell therapy as well in previous lectures. These ones are specific for B cell lymphomas, CD19, loncastuximab, CD20. We have got 3 types of CD markers on the B cells: CD19, CD20, and CD21. Okay, so these are for CD19 and these are for CD20. Then angiogenesis inhibitor, lenalidomide. This belongs to the same group as thalidomide. Okay, so this is an angiogenesis inhibitor. It prevents the formation of blood vessels that the tumors need. Okay, mTOR inhibitors, temsirolimus. Okay, proteasome inhibitors, bortezomib and carfilzomib. These are new drugs for you, and try to memorize them. All right. Okay. Now, here is a classification of non-Hodgkin's lymphoma. We have got indolent disease and aggressive disease. Aggressive disease is more common, 60%. And in indolent disease, we have got either a localized or an advanced follicular lymphoma, but we have got a third type, which is refractory or relapsed. Refractory means it is not responding to therapy. Relapsed means you gave the treatment, the patient went into remission, but the disease has come back, all right? So indolent, localized, or advanced, they are both follicular lymphomas. In aggressive also, we have got localized or advanced. So here it is follicular lymphomas, both local and advanced. And in advanced aggressive disease, we have got a specific type of lymphoma, which is known as diffuse large B-cell lymphoma. Okay. Again, we will go into details when we go to treatment. Now, indolent or low-grade lymphomas, follicular lymphomas, natural history and treatment. There you might find a little bit of variation in the sequence of slides. Okay, so don't get confused. These slides might be a little bit 2 or 3 slides later in your handout, but we have all the slides in the handout. Okay, right. So the median age at diagnosis is 60 years. Treatment options may be limited by patients' comorbidities. Now, notice the median age of diagnosis is younger than previously. We said it is 67 years, which means other types of lymphomas are more common at an older age. Okay. Our treatment options may be limited by the patient's comorbidities. Follicular lymphoma is generally considered a chronic disease characterized by multiple recurrences when standard therapy is used. Okay, some patient may go years without even needing treatment. So it is we said indolent lymphomas, they are slow growing. So sometimes they are so slow growing that they go on for years, just like low-grade prostate cancers. Sometimes we do not even know that the prostate cancer is there, and the person has it for years, 10, 20 years, and he doesn't get any symptoms, and he dies of some other cause, not because of prostate cancer, right? So here again, we can find such cases. Diagnosis, PET or CT scan, immunophenotyping or immunohistochemistry, genetic analysis. We have seen these biomarkers. You have to do a complete blood count, a hepatitis B virus testing, okay, complete metabolic panel, and a MUGA scan or an echocardiogram, because you're doing this too because you have to look at the condition of the heart. Why? Because of doxorubicin. We have doxorubicin in the regimen, which is most commonly used, and we have to know the condition of the heart especially. And this is your metabolic panel. I've shown you previously as well. You can have a quick review over here of your complete metabolic panel. Right. So management of indolent non-Hodgkin lymphoma, follicular lymphoma, grade 1 to 3A comprises 70%. So this is a good thing. 70% of the cases are slow growing cases. Okay. They are easier to treat and they will respond better to the treatment. Stage 1 and contiguous. Stage 2, contiguous means they have gone out of the lymph node in the adjacent tissue. Standard management is radiotherapy alone. Okay, we don't have to give, and we know, it is site-specific radiotherapy. And 40% with radiotherapy, they remain disease-free at 10 years. So very good prognosis. Rituximab is an option. Rituximab is a chimeric antibody. It has got XI in it. It is derived from the mice. And it is anti-CD20 antibody. It is an option for those patients where radiation is contraindicated. Now, indolent non-contiguous stage 2, 3, and 4 higher grade lymphomas, the disease course of indolent lymphomas is characterized by acquisition of resistance that leads to continuous disease, right? So this can happen in some cases. And, this will decrease the quality of life and the duration of treatment response. So when you get higher grade lymphomas, it is easier to understand. I mean, it's easy to understand that the quality of life will be compromised and the duration of response will also be less. Okay, it will be shorter. Right, monoclonal antibodies are changing the treatment paradigm of the patients. Okay, we'll take a break in about, let me see the time. Okay, it's already time for a break. All right, so we'll stop here and we will take a 15 minutes break and then we will come back, and please remind me to start the recording again if I don't do it as soon as we start. All right, so I'll see you in 15
All right.
minutes.
Thank you.
So management of indolent lymphomas, monoclonal antibodies are changing the treatment paradigm. And in the drug list, I've shown you a lot of new drugs, including the monoclonal antibodies. And advanced indolent lymphomas are not curable, unfortunately, because they are slow growing, so you don't diagnose them, and when you diagnose them, they are already at a very advanced and incurable stage. Okay, deferred therapy with observation is recommended for asymptomatic patients, especially older patients and patients with comorbidities. Single agent treatment with chlorambucil or salt cyclophosphamide with or without prednisone is useful in elderly patients with comorbidities. Remission is rare, but palliation may be achieved. Okay. Rituximab, R-CHOP is the most common treatment, and we have got an R-mini-CHOP as well, in which we have got lower doses of all the drugs that we give in this therapy. Okay, so this is a good option for patients who are above 80 years of age. Okay. First-line therapy in younger patients with goal of achieving complete remission, bendamustine, obinutuzumab, or rituximab, or CHOP therapy. I'll show you in the next slide, and obinutuzumab or rituximab. Right, this is for, it's a little bit more aggressive therapy. Then we have got CVP plus obinutuzumab or rituximab. Okay, cyclophosphamide and vincristine and prednisone. Then lenalidomide plus rituximab. This is angiogenesis inhibitor, same group as thalidomide. Okay. Right, so here is a table which is very important. I've written important over here. So it is giving you the tumor type stages 1 and 2, non-bulky, and grade 1 and 2. We have got grades as well as stages of tumors. Then stage 2, bulky. This one is non-bulky, or stage 3 or 4, grade 1 or 2. Okay, we have got actually 3 grades over here, and grade number 3 is further divided into 3A and 3B. Right, so for stage 1 and 2 non-bulky, we have got involved site radiotherapy, which we have seen will sort of produce a remission for 10 years. Okay, chemotherapy regimen, if you decide to give, then it could be immunotherapy with or without chemotherapy. Then watch and wait may be appropriate in certain cases, and we have got alternative therapy, which is bendamustine. I've given the details over here, rituximab, R-CHOP, and RCVP, or just rituximab into 4 weekly doses. Okay, then stage 2, when the patient has indication for treatment in alphabetical order, bendamustine, obinutuzumab. Right, so these are the drugs. CHOP regimen is very common here. I've given you the CHOP regimen. Okay, R-CHOP when it is combined with rituximab, and they are both rituximab and obinutuzumab. They are both anti-CD20 antibodies, and we have got rituximab with CVP, which is given over here. All right, and here are the doses for bendamustine and CVP doses over here. You will notice that rituximab is always 375 milligram per meter square. It is given intravenously on day 1, right? This is what it means. 28 days into 6 cycles for bendamustine and rituximab, and the dose is given per meter square. All right. So comments are that please see indications for treatment with chemotherapy. Bendamustine is not recommended when the patient's creatinine clearance is less than 40 ml, right? So that is sort of stage 3 chronic kidney disease. Right, so elderly patients who are unable to tolerate, they have to be given this alternative regimen, rituximab, 4 weekly doses. Sorry, not 4 times weekly. Did I say 4 times weekly? It is 4 weekly doses. Okay. Then single agent alkylating agents like chlorambucil or cyclophosphamide, they cause DNA cross-linking with or without rituximab, right? So this table is good. We have got many other tables as well. All these tables are good for a quick review of the treatment, right? So we are still at localized disease, non-bulky stage 1, 2, grade 1, 2. Involved site radiotherapy is still considered the standard of care. If radiation is not recommended by National Comprehensive Cancer Network, and the patient is symptomatic, options include immunotherapy plus minus chemotherapy, which includes R-CHOP as well. We can watch and wait. Now it's all your clinical evaluation and your clinical decision. Obviously, it is a team with oncologist and radio-oncologist and nurses and pharmacists, they together make a decision. Now we go on to advanced disease, bulky stage 1 or 2, stages 3, 4, and grade 1 and 2. Indications for treatment are if the symptoms are present, end organ dysfunction, there is a risk of getting end organ dysfunction, cytopenia, which means low cell count of the immune cells, or massive bulk or splenomegaly. The size of the tumor is more than 6 centimeters, and progression over 6 months, and patient preference. So all of these things are taken into account when making a decision for treatment. So treatment options are watch and wait, depending upon these things. If these things are not very serious, then you can watch and wait. Single agent or multi-agent chemotherapy, because randomized trials have shown no survival advantage with immediate treatment. And treatment should be individualized according to the patient's age, extent of disease, presence of comorbid conditions, and goals of therapy. And we will have an attendance after 5 minutes, all right? Right, so advanced disease, let's go to the first line treatment. Addition of rituximab. We have seen that either rituximab or obinutuzumab, they are added to chemotherapy in all cases. So overall response rate is increased, response duration and progression-free survival, they're all increased. Bendamustine plus rituximab, the doses are given in the table as well, and they are given over here as well. So you have to know the doses, and we give 6 cycles for 26 cycles of 28 days each, okay? And they're both given on day 1. So after day 1, you wait until the next cycle, which is after 28 days, and the progression-free survival is about 70 months, which is about 6 years, okay? So it is very good. The response is good. R-CHOP, rituximab, cyclophosphamide, hydroxydonorubicin. This is just another name for doxorubicin, okay? Oncovin, which is the brand name for vincristine and prednisone. R-CHOP, 6 to 8 cycles of 21 days each is associated with 60% reduction in relative risk of treatment failure, right? Then we get higher overall response rate, and it also prolongs the duration of the remission. Okay. Rituximab alone for follicular lymphoma patients with stage 2, stage 4 disease, or stage 1, 2, or early stage follicular lymphoma patients who failed radiotherapy, right? So these stage 1 and stage 2, we saw that the treatment of choice, or we call it the standard of care, that is radiotherapy. If that fails, then they are treated with rituximab in 4 weekly doses, or if you choose, you can combine it with chemotherapy if it is an advanced disease. Okay, and the progression-free survival that we achieve is about 1 year in 77% of the cases. which is all right, better than many other cancers, okay? Now, frontline therapy for elderly patients or patients that are unable to tolerate intense therapy, single agent rituximab is preferred, or you can give chlorambucil with or without rituximab, or you can give cyclophosphamide with or without rituximab. These therapies may be considered. Now, relapsed follicular lymphoma, follow-up to exclude. You have to exclude transformation to diffuse large B cell lymphoma, especially in presence of rising LDH level, if new symptoms arise, if the growth is disproportional, which means it is very rapid, or extranodal disease, right? Then some patient will still benefit from observation, but again, it's a clinical decision. It is the team that is treating the patient. They will have a consensus decision on that. Indications for treatment include symptomatic disease, which we have seen over here, threatened end organ function, cytopenia, massive bulk or splenomegaly, steady progression, like we have seen in the previous slide, okay? So the treatment options are lenalidomide plus minus rituximab, idelalisib, which is a PI3K, phosphoinositol 3 kinase inhibitor, all right? This is something related to cell biology. We'll not go into details. So we give this one if the lymphoma is refractory, which means not responding to alkylating agent like cyclophosphamide and rituximab, okay? So chemoimmunotherapy regimens are not used as frontline therapy in relapsed follicular lymphoma, okay? I hope that's clear. Now, consolidation therapy for follicular lymphoma, this is the second line therapy, again, rituximab, 375 milligram per meter square, one dose every 12 weeks for 2 years, right? So these are bigger intervals, 3 months intervals. This is a category 1 recommendation, which is the top class recommendation. High dose chemotherapy with autologous or allogenic stem cell rescue or transplant. This is the second choice. Obinutuzumab in combination with bendamustine when the patient has failed to respond to rituximab, okay? They are both anti-CD20 antibodies, but if the treatment fails with rituximab, you can go on to the other ones. Now, treatment recommendations for follicular lymphoma, grade 1, grade 2. Again, this is a quick review. And again, this is a table which gives you all the treatment options for first-line therapy for elderly or infirm patients, first-line consolidation or extended dose therapy, second-line and subsequent therapies, second-line consolidation or extended dose therapy. So, as the tumor progresses, you go on increasing the intensity of the therapy or the dose of the therapy or, more aggressive therapy. So bendamustine, obinutuzumab, CHOP, obinutuzumab, R-CHOP, rituximab with cyclophosphamide, doxorubicin, vincristine, prednisone, cyclophosphamide, vincristine, which is oncoin, and prednisone, right? Obinutuzumab, or rituximab combined with the same therapy. Rituximab 375 weekly for 4 doses, okay? Then this is the first line therapy. For elderly infirm, rituximab, we have already seen that. Or single alkylators like chlorambucil or cyclophosphamide with or without rituximab, okay? Consolidation for or extended dosing, rituximab for 2 years, every 8 weeks. Previously, we saw you can give it every 12 weeks as well. Obinutuzumab, 1000 milligram every 8 weeks for 12 doses, all right? Again, second line subsequent in case of relapses or if the therapy is refractory, which means the patient is not responding. So chemoimmunotherapy, rituximab, lenalidomide plus rituximab, radioimmunotherapy, copanlisib, okay, fludarabine, and FND is this one given over here, okay? And then second line therapy again. So these tables are good. They are important. They are good for a quick review of all the categories of treatments, right? Now, this is the last section of the lecture. We now go on to aggressive lymphomas, which the most common aggressive lymphoma is diffuse large B-cell lymphoma. Common cytogenetic abnormalities that we find in DLBCL, gene expression profiling is becoming more common in DLBCL to stratify DLBCL biologically and meaningfully and in relevant prognostic groups, okay? So, genetic profiling. Subdivision of DLBCL is stage 1, stage 2 non-bulky, just like follicular, stage 2 bulky disease, and then stage 3 and 4 diseases, right? And the goal in all of these cases is to cure. The earlier the disease, earlier the stage of the disease, the better the prognosis. The patients who remain in complete remission after 2 years of treatment have better prognosis and they live longer. The International Prognostic Index for intermediate grade or high grade NHL is based on following risk factor. Now, same IPI, age, stage, extranodal, performance status, and LDH levels. This is what we saw in case of follicular lymphoma. Age, again, stage, extranodal, LDH level, and performance status. So same classification and risk stratification is also the same, or the 5-year survival rate is also about the same, 75%, 73%, and 50%, up to 51%, and 25%, and 26%. So the risk stratification or IPI index is the same for follicular and large diffuse B-cell lymphomas. Okay, so initial treatment overview for diffuse large B-cell lymphoma. These are NCCN guidelines. You see stage 1 non-bulky, stage 1, 2 bulky, stage 3 and 4, same regimen. R-CHOP 3 cycles, radiation therapy. This is a category 1 recommendation, which means a strong recommendation. Or you can give 6 cycles with radiation therapy. Same, 6 cycles for radiation therapy. Here you can give 3 as well if it is not very serious. Again, 6 cycles and category 1 recommendation. And the doses have been given over here. We have got a mini CHOP, or mini CHOP as well. So these, if you compare the doses, I've given the doses over here or somewhere else for mini CHOP, the doses are lower, maybe in the next table. So mini CHOP has got lower doses as compared to R-CHOP, okay? So these are the alternative drugs, in case there is a left ventricular ejection fraction is low, is poor, then we cannot give doxorubicin, right? Because it is cardiotoxic. So in this case, we choose other regimen that do not have doxorubicin in very low doses, where they have written maintained at base doses, low doses, but you have to take into account that doxorubicin can cause acute heart failure, and that could be permanent, irreversible. So you have to be very careful with doxorubicin. Right. So, and all these acronyms, they have been explained in the notes below this table. Now, CNS disease is difficult to treat. CNS involvement and subsequent need for prophylaxis in DLBCL, there is no standard of care. In prophylaxis is given 4 doses of intrathecal methotrexate or cytarabine are recommended. You can give systemic methotrexate as well. Parenchymal disease should be treated with systemic methotrexate 3 gram per meter square on day 15 and 21 of R-CHOP cycle, right? The C is for cyclophosphamide. Growth factor support is necessary. Leptomeningeal disease means the primary tumor was somewhere else. So this basically means a metastatic disease. You can give this intrathecal methotrexate or cytarabine, and you place an Ommaya reservoir that I'll show you in a second. And systemic methotrexate can also be. So this is what Ommaya reservoir is. You place the catheter in the lateral ventricle. You are actually giving the drug into the cerebrospinal fluid. Okay, so this is an actual patient in whom the catheter has been placed, and there you are giving the drug. Relapsed refractory diffuse large B-cell lymphoma. Risk factors for relapse after 2 years of disease-free survival include age 60 years, advanced stage, and IPI score of greater than 2.49. All right, so that means there is a more complex way of calculating IPI score. The goal of treatment is cure again, okay? So that is a good thing. Second-line chemotherapy with intention to proceed to high-dose chemotherapy, followed by autologous stem cell transplantation, and we'll see more details in the table that is coming up. We have got a DAP regimen, SHAP regimen, GDP have given the drugs over here, GEMOX, gemcitabine oxaliplatin, ifosfamide, right? So over here, in GDP, you see it is platinum. This P stands for platinum-based, gemcitabine, dexamethasone. So platinum-based could be either cisplatin or carboplatin. Mine, because you're giving ifosfamide, both cyclophosphamide and ifosfamide damage the bladder. They cause hemorrhagic cystitis. So Mesna is protective for that, okay? It forms a coat in the bladder, over the bladder, epithelium, so it protects the bladder. Now, here is the treatment summary for diffuse large B-cell, first-line therapy with poor left ventricular function. We avoid doxorubicin. Patients above 80 years, we give them a mini chop, which, yes, I've given you the doses of mini chop over here. Cyclophosphamide is about the same dose, but doxorubicin is reduced dose. Vincristine is 1 milligram. Prednisone is 40 milligram instead of perhaps 100 to 120 milligram, right? So all doses are reduced in mini chop. Second line therapy patients intending to proceed to autologous DAP, SHAP plus minus rituximab. Okay, alternative treatments are also given. Second line therapy, not candidates for high dose therapy, bendamustine, rituximab. So you have to decide on the doses and the therapy. You have to choose. These are just the guidelines, all right? So, but at this stage, you have to know some of these, and I have written that all the tables are important. Now, very aggressive lymphoma, which is Burkitt lymphoma, right? Burkitt lymphoma, the most rapidly proliferating human malignancy. There are 3 clinical variants: endemic, sporadic, and immunodeficiency stages associated. So, most rapidly proliferating, it grows so fast that it can double its size in a couple of days, right? Or maybe in a week. The goal is to cure. Durable remission is possible in 60 to 90%. So this is a good thing, it is the patient can benefit from therapy. Cure is achieved when treating with dose-intensive multi-agent. So this occurs in younger patients. So we can give a dose-intensive chemotherapy. But the problem is, you can give CHOP or R-CHOP. Sorry, this is not the adequate treatment. I'll give you the treatments in the next slide. Tumor lysis syndrome, which causes electrolyte imbalance in the body. It happens because the tumor is growing so fast that the blood supply does not keep pace with it. And so the tumor cells break down and all the intracellular electrolytes come out like potassium and calcium. There's not much calcium in it, but you get electrolyte disturbances, all right? The regimens include intensive multi-agent chemotherapy. You have intrathecal chemotherapy due to the tendency of the disease to disseminate, right? So you give it prophylactically in either systemically or intrathecally. Recommended intrathecal agents include methotrexate and cytarabine. That was there in the previous cases as well. So here is initial treatment for Burkitt lymphoma, low-risk disease and high-risk disease. Now you see we have got different treatments. We do not have R-CHOP over here. And these are the standard of care, almost the same in both, in low-risk disease and high-risk disease. We have almost the same treatments, okay? Maybe the number of cycles you can increase over here, but the treatment regimen or the protocols are the same. Okay, over here, if you see, again, they are the same. Right. Now, Burkitt's lymphoma, relapsed disease. Second-line therapy is only considered in patients with reasonable duration of first remission. There is no definitive second-line regimen. And, when we have no treatment, we advise the patient to go to clinical trials for new drugs, okay, that may or may not benefit them, but it's up to the patients entirely, the patient's choice. We have to get his consent. Chemotherapy with the rituximab containing regimen, followed by high-dose therapy in autologous or allogeneic stem cell transplantation may be considered. Again, treatment for Burkitt lymphoma, CHOP or R-CHOP is not adequate, okay? So same treatments that I've shown you previously, induction therapy for low-risk combination regimen, high-risk, same therapies over here, right? And second-line therapy is given over here. And I've given you the drugs included in these therapies. So you can read it on your own. It's no use if I read these protocols. And they are there for you to look into details later on, okay? And that is all for this lecture. And we will have a quiz from this lecture and Hodgkin lymphoma, all right? If you have any questions, you can ask me now. And by the way, I'll take attendance now. So first, just let me stop the recording.